most respected teachers, senior colleagues and friends. I'm Dr. Ayyappan Nair. I'm from Manipal Hospitals, Bangalore. And I'm extremely thankful to Team Kolkata, Rajiv Raman sir and Suneet sir, Soumya Deep. All of you have been very good, I mean, very, very kind. And yes.
Can we see
The screen is not coming up. Yeah. So extremely thankful to all of you, and good morning to the chair as well. So I'll be speaking on the Bankart surgery, management of failure, and further options. So here, the cardinal principles which I feel that we should keep in mind is about patient selection. Patient selection would be like, it's not the same surgery for a first-time dislocator or multiple-time dislocator. It's not the same surgery for if there is a bone loss. It's not the same surgery for a contact athlete. It's not a same surgery for laxity. So the surgery is different. The patient selection should also be very, very different. So it is basically choosing the right surgery for the right patient, and always getting it right the first time is most important, because always the primary surgery gives the best results. The revisions have lesser results. So always I think we should keep in mind about that. And coming to the incidence, when you look at different papers, the incidence is quite huge. On the primary Bankart, that is touching around 18%, that is not 20%, that one in five patients are going to fail. So coming to failure analysis, there have been different papers talking about different causes and what are the possible failures, reasons for failure. So name it like hyperlaxity, technical problems, bone defects in the glenoid and the humerus, which has been discussed now, return to contact sports, traumatic recurrences, age, and other pathologies. But I think the most comprehensive paper would be from Pascal Boileau, which came in 2006, a failure analysis of 131 cases, which was quite comprehensive. So the takeaways from this paper was that the age, younger age, higher recurrence. So more the higher the age, it reduces. Contact sports, higher recurrence. Competitive sports, higher recurrence. Hyperlaxity, anterior and inferior hyperlaxity, higher recurrence. So if there's a bigger hill sash, the superior hill sash, like if it is seen in extenotation, higher recurrence. So with this, they devised the ICE score, which is a score less than 3 would be suitable for a Bankart, and a score above 3 would be better for other procedures. So coming to, so this is another paper, 91 cases. So the amount of risk, the percentage of recurrent instability was 15%, and delay to recurrence was interestingly like around 17 months. So we should expect the recurrences like touching around 1.5 to 2 years at time we should start seeing recurrences. Now again, the takeaways from this paper was, so there are certain important factors which we have to keep in mind which are responsible for the failure. One is the glenoid bone loss. So there has been discussion right now about the glenoid bone loss, if it is like a significant bone loss, about 25%. There are some papers talking about, like Shin et al., there's a paper talking about 15%. So it is variable. From my side, I would take 15%. I would like to be slightly on the aggressive side. So if it is more than 15% bone loss, it is important and critical to me. A large hill sash has to be addressed. So a stretched out IGHL, we are talking about IGHL which can be stretched out with multiple dislocations. So again, it's an important factor. How many number of anchors we use is very important. Less than 3 number of anchors can fail. And if there is extreme anterior hyperlaxity, like with extreme external rotation, again, these are the main contributing factors which you have to keep in mind when you're thinking about avoiding failure. So again, there is an interesting question asked, and to answer that as well. So when you look at the bone loss could be of 2 types, avulsion type or erosion type. Erosion is like on the right side of the picture. So here they have higher recurrence. So we are looking at, if there is more than 15%, I would do a LATARJET on erosion type. At the same time, if it is an avulsion type, and we can, avulsion types, if it is very well fixed, then definitely we can have cases without any recurrence. Excellent paper from Sugaya et al. Sugaya team will come out because he's fixed all with special techniques, trans-osseous techniques. Okay, he's got a particular way of repairing it, and excellent results, no recurrence if an avulsion fracture is nicely fixed. So here, this is the reason why in erosion there is quite a bit of hyperlaxity as well. There is laxity of the capsule as well. So that is why it fails. Now, coming to surgical technique, what all we have to do to be, that we have to be careful and how to manage this would be, in any case, mobilizing tissue is very important. That is the labrum and the capsulable tissue has to be very well mobilized. The capsular plication, especially the plication at around 6 o'clock and 5:30 is very, very important. We can use matter sutures so that we get a good plication. The IGHL tears, haggles should be addressed. So soft tissue insufficiency, we have to specifically look at ALPSA lesions. So we have to do adequate mobilization in the ALPSA, lift up the capsulolabral complex. Then sulcus signs have to be, if there's a sulcus sign, we have to take care of that. I would do a rotator interval closure in those cases. And what happens is, whenever we are preparing the labrum, we also have to prepare the cartilage. That means we have to take a small rim of cartilage from the side of the glenoid, because that is very important. So that, because there's no healing which happens between the soft tissue and the cartilage. The healing happens only between the bone and the soft tissues. So we have to take a small rim of cartilage. That's very important in the healing. Then please look at this picture. So this shows that whenever we're putting anchors, the anchor should be put on the glenoid face, not on the medial side. That also helps in better plication. Then number of anchors should be always more than 3. 3 or less than 3 will fail. So these are the things we should keep in mind when we think about how to avoid failures. So if a case of failure is coming to me, what do I do? Definitely I would do a CT scan, and along with that certain X-rays. But the CT would be most important to me, and I would do a bone loss quantification. So an MR arthrogram would be my choice of radiography. Why? Because I would like to study the haggle. I would like to really know about the capsule, how much of laxity is there, all that, and any rotator cuff tears, all this, and I will do an MR arthrogram. So now we now know that I have a particular case. Now what are my options? My options would be like this. My options are: number one option, a revision arthroscopic Bankart plus remplissage, an arthroscopic or open LATARJET, a dynamic anterior stabilization, or a subscapularis tenodesis. So I'll come to one by one. So what is my indication for a revision Bankart? For me, a revision Bankart would be like if the bone loss is very less and the tissue quality should be good. But personally, I would not do this, because even with the revision Bankart, there's a very, very high failure rate. A revision Bankart failure rate is around 10 to 43%. 43% is very, very high. So I would definitely not do this now. This is my earlier video. So I don't do this anymore. If we are doing it, then these are the things to keep in mind. There should be adequate tissue mobilization, a cartilage removal and a nice bed preparation, inferior anchor placement, and matter sutures. This will definitely help in a nice revision. The results are the problem. When we look at the literature, this is the results. 43% to 43% is a huge recurrence after with a revision Bankart. So the reasons are these: because of soft tissue quality, decreased sites of available sites for the suture anchor placement is much lesser, and the healing capacity overall in a revision scenario is less. So what is my surgery of choice? I would definitely do an arthroscopic LATARJET for a failed Bankart. That is my surgery of choice, irrespective of the soft tissue or the bone quality, but because this would give me a one-stop answer to my questions. So here, this is a particular patient who had 2 times Bankart, failed, and we did an arthroscopic LATARJET. So whenever I do an arthroscopic LATARJET, I always do a remplissage, irrespective of the remplissage, if it's especially revision cases, irrespective of if it is on track, off track, I always do a remplissage along with arthroscopic LATARJET. The advantage of the arthroscopic LATARJET is that it gives you scopy access posteriorly. I also repair the capsulolabral complex back after doing the LATARJET. So all this is possible with an arthroscopic LATARJET, and we have excellent results with this. This is the results of these patients after 6 months and immediate post-op CT. So the patient has gone back to full range, and so this is my procedure of choice. It's got excellent results. So if you look at recurrence and all, it's excellent results with the arthroscopic or the LATARJET. It is much, if you're doing open LATARJET, it's much cheaper and better clinical scores. And the other thing which I would suggest is, if there is bone loss is subcritical, we can always use a DAS technique. This is our technique of DAS, which we recently did. And we use an Arthrex system of tightrope and to do the DAS. So we have evolved this technique, is under publication. So this is my summary. So the patient selection is very important. Rigorous techniques to avoid the failure we have to keep in mind. Revision Bankart has high failure rate, so I would not do it personally. So my surgery of choice would be an arthroscopic LATARJET, which gives excellent results in my hands. DAS is a great option if there is subcritical bone loss because it gives you soft tissue support. Thank you so much. I welcome all of you to Manipal Shoulder Conference. Please come. Thank you so much.
Thank you, Dr. Ayyappan. If you have any questions, couple of questions. If no questions,
Okay.
thank you. Okay.
Can you expand on this last technique that you mentioned?
Yes.
I haven't heard about it.
So it is dynamic anterior stabilization. So Ladderman had started this technique. I mean, he had reinvented rather this technique, where we take the long head of the biceps, we detach it, we make a split in the subscap, and fix it anterior to the glenoid. So the fixation on the top of the glenoid could be on the glenoid face or on the side. The point of fixation would be at 3 o'clock. Why? Because the IGHL is normally fixed at 3 o'clock position. There are different techniques of fixation, like, we can fix it with like a tenodesis screw. And what we have modified is we have used a tightrope, soft tissue tightrope, like how we do in cordyceps. So we have called fiber tack tightrope. We have used that, and we have that's how we have done it. Why? Because because glenoid is much smaller compared to the knee. We don't want too much of a bone loss there. Chance of fracture and all is there. So this is, and it's very easy to do because so we have. That's why we have done this with, just like how we do some similar to that ACL. So we just pull it in. Only thing is we need an anterior axis. The only thing. It's a great technique. We just did that, and we sent for publication. So we're waiting for that, and then planning to start on long-term series.
Thank you, Dr. Ayyappan Nair. We will go on to the next presentation. There's a change in the itinerary. We are going to